Over to you, sir.
Good afternoon, esteemed chairpersons, senior faculties, and esteemed delegates. So this is a great opportunity for me, and it's an honor to talk on incremental hemodialysis. I will say any talk or discussions, wherever it is happening on incremental hemodialysis, it has got practice-changing implications. First to discuss about incremental hemodialysis, it is very mandatory to know how the practice of dialysis prescription changed over the past 50 years. Before 50 years, especially in the West, the standard dialysis prescription, it only had 1 per week or 2 per week hemodialysis. And many patients with end-stage renal disease do not have any access to dialysis programs, and they do die. But a major shift or major change happened in 1973 with Medicare ESRD program in USA, where the patients where all insured patients were eligible for dialysis, and that too 3 per week hemodialysis. From then, 3 per week hemodialysis became a standard of care, and it remained unchallenged till now, till recently I will tell. And it is only very recently other evidences and incremental hemodialysis and other options are being explored. Even though incremental hemodialysis is being suggested even 10 to 20 years back, it hadn't gained its popularity. Till now, it is a standard 3 per week, but it is very recently, there are a lot of evidence coming up, positive evidence coming up regarding incremental hemodialysis. So what is incremental hemodialysis? It is just means that performing less than 3 sessions of hemodialysis per week at the initiation of the dialysis treatment if a patient have a significant residual kidney function. That means it is an individualized dialysis prescription based on residual kidney function. Firstly, I need to break the misconception.
Dr. Arun, sorry to interrupt you. The slides aren't moving.
So this is the timeline of how the dialysis prescription changed over time. Up to 1953, it was less than 2 or 1 per week. With 1973, till recently, it is 3 per week hemodialysis. And it is very recently we have incremental hemodialysis and all coming up with more and more evidence. And incremental hemodialysis, as already mentioned, it is doing less than 3 per week hemodialysis if the patient have a reasonable residual kidney function. Let me break the misconception. Incremental hemodialysis is not equal to 2 per week hemodialysis. It is something more. It is a more personalized approach. It is based on, it all revolves around the residual kidney function. It is actually a tailored approach with individualized treatment goals, more patient-friendly prescription, and it is found to enhance the quality of life and decrease healthcare cost. So is it evidence-based? That's the first question we need to address or we need to discuss before going further. Very recently, we have the recent meta-analysis on incremental hemodialysis published in Clinical Kidney Journal, this January 2024. They compared incremental hemodialysis versus conventional 3 per week hemodialysis in end-stage kidney disease. And the conclusions are very promising. What they found that if the patient is on incremental hemodialysis, it do preserves the residual kidney function. And also patients on incremental hemodialysis have less hospital admission. Additionally, on subgroup analysis, for patients with residual kidney function more than 2 ml per minute or a residual urine output of more than 500 ml per day, this patient has less cardiovascular events and mortality on incremental hemodialysis. So concluding, incremental hemodialysis is safe and attenuates hospitalization and loss of residual kidney function when compared to conventional hemodialysis. Also, incremental hemodialysis may improve cardiovascular outcome and mortality in appropriately selected patients. So what is residual kidney function? It is the key player, which is a determinant player, or we can decide on incremental hemodialysis. It is the ability of the native kidney to eliminate water and uremic toxins. It has got several advantages, like this can clear the middle molecules, removal of protein-bound uremic toxins, improved BP control, maintenance of euvolemia, superior phosphate control, reduced erythropoietin stimulating agent requirement, and reduced malnutrition. Overall, there is a better quality of life and better survival if there is residual kidney function. So in a nutshell, 2 per week hemodialysis plus a reasonable residual kidney function is superior to 3 per week hemodialysis as per the available evidence. So we all can argue, why not 3 per week hemodialysis in a patient with residual kidney function? As already told, more hemodialysis, especially 3 per week hemodialysis, more will be the speed of decline in the residual kidney function. Why it is happening? This is because of the exposure of the blood to the dialysis membrane. Whenever the blood comes in contact with the membrane, some amount of inflammation is triggered, and that do damage the residual kidney function. Also, the blood is exposed to the endotoxins from the RO water. That too triggers the inflammation. That affects the residual kidney function. And also because of the ischemic insults during hemodialysis. We are removing the fluid from the intravascular compartment. So there will be transient intravascular volume depletion during dialysis. So it could be documented hypotension or undocumented hypotension, or even if there is no hypotension, there will be renal hypoperfusion during that time, and that can lead to loss of residual kidney function. So more hemodialysis, more will be the speed of decline in the residual kidney function. So a patient with high residual renal function subjecting to 3 per week hemodialysis, we are taking away the residual kidney function. And all the evidences do favor 2 per week versus 3 per week hemodialysis. Greater is the residual kidney function preservation in 2 per week hemodialysis group. So again, 2 per week hemodialysis plus a reasonable residual kidney function is superior to 3 per week hemodialysis. But there is an issue. What is the reasonable residual kidney function? If it is not properly defined, it can lead to lack of uniformity, and this can lead to non-uniform practice patterns, potential risk of underdialysis for some patients, and also we need clear guidelines for including patients in the clinical trial. Also, we need to develop a good tool to quantify residual kidney function, or some guidelines to pick up patients with residual kidney function. So how to quantify residual kidney function? So ideally, urine should be collected in the entire interdialytic interval, and we have to measure urine, urea and creatinine from the measured urine, and the volume also. But there are certain studies telling that the 24-hour urine on a pre-HD day is sufficient. Then we have to have the blood urea and creatinine. A single value is not sufficient. We have to have 2 blood urea and 2 serum creatinine values taken at the beginning and at the end of timed urine collection, and take the average. We have to calculate the renal urea clearance and renal creatinine clearance. Urea clearance underestimate GFR due to tubular reabsorption. Creatinine clearance overestimate GFR due to tubular secretions. So mean of urea and creatinine clearance is shown to correlate well with inulin clearance. So that is how we can quantify the residual kidney function. And what is the minimum residual kidney function required to suggest or to start a patient on incremental hemodialysis? For this, we can just do some calculation. So 1.2 is the single pool KT by V for a standard hemodialysis treatment we all wish for. So if we convert it into a weekly standard KT by V, so 3 per week, if it is 1.2 for single pool, it becomes 2.3. For 2 per week, it becomes 1.53. The equivalent urea clearance is 9.3 or 6.15 for 2 per week. So there is a difference of 3. So this is a differential 3 ml per minute is the urea clearance, which is the minimum threshold of the residual kidney function at which we can suggest a 2 per week hemodialysis and patient will be on incremental hemodialysis schedule. But KDOQI guidelines suggest that even a residual kidney function of more than 2 ml per minute per 1.73 meter square is sufficient for sufficient to have a good quality of life for patients on incremental hemodialysis. But we need to be more practical. I just discussed how we are calculating the residual kidney function. We have to have a timed urine collection, and we are asking the patients to collect their urine in the interdialytic period. Usually it results in under collection because the normal tendency of us is to go to the toilet and void. There could be under collection, and it is very cumbersome, and we have to collect blood at 2 points. It is costly also, and moreover at 1 point measurement is not sufficient. All the patients on incremental hemodialysis should be serially monitored for how the residual kidney function is behaving over the time. So this is not very practical. So consideration should be given for a more practical approach to pick up patients with residual kidney function. So, and also whatever we are discussing about the residual kidney function in terms of clearance of urea and creatinine is all a glomerulocentric approach. We are all assuming that the glomeruli is the only area through which the uremic toxins are being excreted. It's not true. There are tubular secretions also. There are many organic anions which are protein bound in the blood, which are uremic toxins. These protein bound organic anions are secreted into the proximal tubules using organic anion transporters. And these organic anion transporters can achieve a concentration of these organic anions in the tubules 100 times more than that in the serum. So tubular secretion constitute a major, or it's a key player for removal of organic anions, toxin bound, protein bound toxins. So this will be never captured if we consider or if we assume that the residual kidney function is purely from the glomeruli and we keep on measuring the urea clearance and creatinine clearance. And also it is very worth to note that a significant proportion of urine that is coming in a dialysis patient is actually driven by the organic anions which is secreted into the tubules, which attain high concentration, which draws in more water also. So we need a better tool for monitoring or picking up patients for incremental hemodialysis. One proposed monitoring tool by Calendar et al. This is at 10 points, which is very worth discussing. So we have the first one is a residual urine output of more than 0.5 liters per day, interdialytic weight gain less than 2.5 kilogram or less than 5% of the dry weight at interval of 3 to 4, that is when the patient is on 2 per week schedule, appropriate body size relative to residual kidney function, infrequent or readily manageable hypokalemia, infrequent or readily manageable hypophosphatemia, good nutritional status without overt catabolic state, appropriate responsiveness to anemia, limited or easily manageable comorbid condition, satisfactory health-related quality of life. So we are assessing the patient more globally than strictly focusing on the clearance of urea and creatinine. So if all these parameters are fair enough, we can consider 2 per week or even lesser dialysis for patient to start with, and we have to assess the patient monthly using this tool, or we have to assess the patient globally and assess whether the patient is having an adequate dialysis or not. So this is more practical rather than monitoring every month with the residual collecting the urine and collecting urea and doing the urea clearance and creatinine clearance. So what is the adequate urine output for incremental hemodialysis? That is still a question of discussion, because 0.5 liters per day of urine, it is very good, and it is usually recommended to select patients based on this 0.5 liters per day residual urine output. But in choice study, even 250 ml, that is 1 cup of urine daily, was associated with greater survival and quality of life and lower inflammation and significantly less erythropoietin use. So more than 500 ml per day is very adequate. 250 to 500, case to case basis, we can select patients for incremental hemodialysis. And going into the next level, So being more investigational or going into more precise manner, there are tools to predict residual kidney functions like using serum beta trace protein and beta 2 microglobulins. These are middle molecules which are not usually removed using the conventional dialysis, will be removed only if the patient is using high flux dialysis or patient is on hemofiltration. So these levels will be higher in patients with low residual kidney function. So there is a predictive equation based on beta trace protein and beta 2 microglobulin from which we can predict the residual kidney function, and there is a substantial agreement between the predicted and measured residual kidney function at a cutoff of 2 ml per minute per 1.73 meter square, which is the recommended minimum to have a patient on incremental hemodialysis. And some considerations we have to make while we select patients for incremental hemodialysis is the primary kidney disease and comorbidities. Residual decline in the residual kidney function is very high in patients with diabetic nephropathy, chronic glomerular nephritis, and with if you talk about comorbidities, patients with heart failure because of decreased effective intravascular volume because of low cardiac output, and obesity. So if these patients are on incremental hemodialysis, we have to keep in mind that the residual kidney functions will be going to in the declining steep. This steep will be it will be in a very steep manner. So we have to exert caution, periodically reassess the patient. But the residual kidney function, the loss will be comparatively slower in tubulointerstitial disease, especially in adult polycystic kidney disease and ischemic nephropathy. So these patients constitute a group where we can, to a reasonable confidence, we can be prescribed to incremental hemodialysis, and we can assure that they will be on the incremental hemodialysis schedule that is less than 3 per week schedule for a much longer time. And other than the health benefit, there are other potential benefits of incremental hemodialysis too. One is on the prolongation or longevity of AV fistula. So if the patient is on incremental hemodialysis, the fistula is going to get cannulated very less. So more and more pricks in the AV fistula, more and more is likely for the fistula to become stenosed and thrombosed. So incremental hemodialysis, we can have a better longevity of AV fistula. Obviously, cost reduction, which is very, very important in our part, and it gives incremental hemodialysis gives an opportunity for the patient to engage in activities outside dialysis unit, more activities in dialysis unit. And cost is a major factor. This is a costing study we done, which we compared 2 per week and 3 per week hemodialysis, published in Hemodialysis International. What we found that catastrophic healthcare expenditure, that is the family is spending more than 40% of the total household income for the dialysis, and distressing healthcare expenditure, that means the family needs to borrow money or sell their assets to meet the expense for hemodialysis, is significantly more in 3 per week hemodialysis. That is, it is not the direct cost of the dialysis that matters. There are a lot of non-direct and indirect cost for hemodialysis. This includes the cost of travel. Many often the travel cost is more than the cost of the hemodialysis that the patient has to pay in the hospital. One bystander has to accompany. He is not going for the work, the loss of pay, and also the loss of pay for the patient also if the patient is in a working age group with working potential to go to job. So a cost factor is very important. And few considerations that we must make while we are prescribing a patient on incremental hemodialysis is on RAS blockers. Whether these patients should be on RAS blockers. It is a well-known fact that RAS blockers can preserve residual kidney function. But these RAS blockers are not, especially ARBs, are not easily dialysable. They remain in the blood during the dialysis. And during dialysis, there is intravascular volume depletion, and there is a RAS activation which will be blunted by the RAS blockers. So there will be a risk of intradialytic hypotension on patients, for some patients who are taking RAS blockers. So if there is an intradialytic hypertension is happening, so it will lead to decline in the residual kidney function, and your incremental hemodialysis may not work well. And also, if for patients on incremental hemodialysis, still there is a reasonable residual kidney function, and that is from that function, some amount of potassium is being excreted, and that too will be blunted if you're using RAS blocker. So there is a risk of hyperkalemia, especially patient is on 2 per week hemodialysis, so potassium removal through the hemodialysis is not that adequate as 3 per week hemodialysis. So it is a complex thing. So if you're using RAS blockers, it should be in a judicious use only if the patient is on incremental hemodialysis schedule. Second is on loop diuretic. So there is a common thought that the loop diuretic is very beneficial, especially if patient is on less than 3 per week hemodialysis, to maintain or to augment the urine output. So that is true to some extent because it increases the salt and water excretion and also some amount of potassium excretion, and it helps to maintain euvolemia. But what is the dose of loop diuretics required? Ideally, the dose of loop diuretic required is very high, like 500 to 1000 milligram per day of furosemide to significantly improve the urine output, because the loop diuretic first need to come inside the tubule through tubular secretion to augment the urine output. So in advanced CKD, when the number of nephrons are less and there are a lot of other organic anions which is competing with the loop diuretics to get inside the tubule, we need a higher dose. And so using this high dose, there is a risk of sunlight-induced bullae and sometimes the risk of ototoxicity. Additionally, loop diuretics compete with organic anion transporters. So there are a lot of protein-bound organic anions which are uremic toxins. Because of these competitions, the uremic toxins cannot enter the tubules if you are using very high dose of loop diuretics. The removal of the organic anions is one of the mechanism by which the incremental hemodialysis is proposed to be superior or beneficial when compared to standard 3 per week hemodialysis schedule. So the use of loop diuretic should also be very judicious. Second thing is about how much protein a patient on incremental hemodialysis should consume to protect the residual kidney function. Before dialysis, we all recommend to reduce the protein intake to 0.6 to 0.8 gram per kg per day. But once the dialysis is started, the recommended protein intake is 1.2 to 1.5 gram per kg per day. But if the patient is on incremental hemodialysis, so whether this high protein intake, can it affect the residual kidney function? Till now, we do not have much evidence to give a final conclusion or final recommendation, but a reasonable approach is to use high protein diet on the day of hemodialysis and a low protein diet on other days. This is because hemodialysis is a hypercatabolic state because of the cytokine activation during dialysis and loss of some amino acids during hemodialysis. So that is a combined dialysis diet program. It should be explored when the patient is on incremental hemodialysis schedule. And one caution, using NSAIDs and other nephrotoxic medication, if the patient is on 3 per week hemodialysis with no residual kidney function, it is safe. But if the patient is having residual kidney function and the patient is on incremental hemodialysis, it should not be used because the residual kidney function is the key factor that determines the outcome of the patient while the patient is on incremental hemodialysis. One bottleneck which we all have to tackle while we place a patient on incremental hemodialysis schedule is the interdialytic weight gain and the amount of ultrafiltration required. The amount of ultrafiltration per hour should be less than 10 ml per kg, ideally, and maximum we can go up to 13 ml per kg, but ideally it should be below 10 ml per kg per hour. But if the interdialytic weight gain is very high, like we have to remove a good amount of ultrafiltration, it can lead to cramps, dizziness, fatigue, and even hypotension during dialysis, and it can affect the residual kidney function. Even if the patient has got a very good amount of residual kidney function, if the interdialytic weight gain is very high, that patient cannot do well in an incremental hemodialysis schedule. We have to motivate the patient to cut down the salt and water intake. We have to motivate the patient to buy a home weighing scale, daily monitor the weight, and avoid high interdialytic weight gain. And one main issue we face while we prescribing incremental dialysis is the transition. So one point, we have to have the transition from 2 per week to 3 per week, but the patients get used to to the easiness of 2 per week hemodialysis, and the patients will be very reluctant to change to 3 per week. So at the time of initiation of the dialysis, if the patient is on incremental hemodialysis, the patient should be counseled that we will be measuring the residual kidney function, or we will be assessing the patient globally regarding the dialysis adequacy, and you may have to go to 3 per week hemodialysis at any time. So regular counseling is needed and to have a smooth transition. And monthly we have to monitor the patient. Collecting the whole 24-hour urine output and doing the creatinine clearance and urea clearance is not very essential. We can assess the patient globally based on all the health parameters like quality of life, nutritional status, phosphate, fluid overload status, etc. So on concluding, incremental hemodialysis is a very good concept. Though previously proposed, it is gaining momentum only very recently with the very good quality meta-analysis coming up, and it relies on the residual kidney function, and also we have to consider the comorbidities, life expectancy, medication adherence, medical resources, and dietary intake. And judiciously and carefully selected patients on incremental hemodialysis can have better survival and better health-related quality of life. And we have to weigh 2 advantages and disadvantages. The advantages means it's more HD free time, reduced medical cost, residual kidney function preservation, more clearance of middle molecules, more clearance of protein-bound organic anions which are uremic toxins, and more vascular access preservation. And there are disadvantages too. Less solute clearance, volume management is sometimes it can become very difficult, and only because of the volume management issues we may have to drop the incremental hemodialysis, and less dietary restriction if the patient on 3 per week dialysis, and less pill burden if the patient is on 3 per week hemodialysis. Thank you.